We move on. The next very, very interesting session is life after cancer. What happens when the patients finish treatment? They have to go back to the university, they have to go back to work. So I think we will do the 3 presentations and then we will have time for questions and answers. I will introduce the 3 speakers. The first one is Professor Carlo Alfredo Clerici. He's a psychologist, he works in Milan, Italy. The second one is a patient survivor, Tom Grew from the UK. And the third one is Diego Villalón. He's a social worker from Madrid, Spain. Thank you very much.
Thank you. Good morning. I have to thank the organizing committee and Dr. Alvaro Lasaleta for invitation. I will help by a written text because my English is not so good as I would like. I have some problems at the moment of the debate. The aim of my presentation is to illustrate the main issues about the monitoring of quality of life of cancer survivors. Every people here in the room knows how it's difficult to the impact of the disease and the life of an adolescent. And because the disease onset is usually painful, sudden, and very, very distressing. Life dramatically changes, and the adolescent must quick adapt to this change. And death and destruction are often a consequence inevitable of major disaster. But the work in cancer field in cure of adolescent and young adults fortunately testify for many cases extremely encouraging. In fact, the consequences of having had a cancer are not always negative. Some people have ever talk about the concept of resilience. This is a patient, is a testimonial of our Progetto Giovani in the National Cancer Institute of Milan, where I work since 1997 as a medical doctor specialized in clinical psychology. I'm basically a psychodynamic psychiatrist. And over the years, I have the privilege of observing various kind of clinical trend and adaptation of patients. And many patients told of being able to draw from the experience of a disease the help to live with more meaning and more forcefully. And the quality, what is in general, the quality of life of cancer survivor? Much depends on how we define the quality of life. I found very interesting the definition of Sigmund Freud, Leben und Arbeiten, to love, the ability to love and to work is a still important concept. And the situation changes if you use some questionnaires and the modern system of investigator quality of life. In these slides, I present some data from a study of a small sample of cancer survivors with osteosarcoma cured more than 5 years ago, 20 young adults now. And if you investigate their quality of life, we found basically the same quality of life of general population. The mean line of general population is 50, and a very small part are over this scale. The same is if we investigate by psychopathological criteria, if you use a test used in psychiatry, SGL-90, only one person shows psychopathological symptoms and behavioral problems. But the question is more interesting if we look more closely the problem of this small sample. 20 people. One had a pregnancy when still was minor. Only 2 lives alone. 4 had the necessity of treatment by psychopharmacological and psychotherapy. 2 only with psychotherapy for a period from few months to some years. Every day there is a surprise. 2 weeks ago we had a patient of this sample who came in our hospital for a psychotherapy session and tried to inject bleach in his vein. And this factor surprise it's very difficult to understand. Certainly, this action is not a strong demonstration of resilience, probably a demonstrative acting by a person with a borderline personality, and we need to know more about these problems and long-term problems of adaptation to life, not only to the disease, oncological disease. I come from Milano, quite known for fashion, Armani, Prada, Dolce & Gabbana, and I like this image, shows the evolution of fashion, the buttons of male dresses, and also concept of psychiatry and psychology have an evolution during the year. The concept and the way to observe the adaptation, the long-term adaptation of patient started years ago with the psychological and psychopathological symptoms, anxiety and depression, and more recently we try to use concepts such as distress, trauma, PTSD, and in recent years, the concept of resilience. Resilience is not a black and white trait, is an aim for the whole system of support of patient during the cure, and the ideal aim and not all patients reach this resilience. I show you some general aspects of impact of disease on adolescents. Adolescent is a difficult period, complex period, is fascinating and difficult to understand by adults, and adolescents give challenges and obstacles to people, and the aim are achieving independence, physical, emotional, and material. To develop a sense of identity. And this sense of identity is not very easy, and every day there is a surprise. 2 weeks ago, another patient, not of the sample I presented, showed to her doctor content of his handbag and very fashion brace and other dresses. What is the problem of disease on adolescent and young adults? in the same period when you have to feel strong and beautiful, the disease and the treatment make you feel weak and vulnerable. And this is a problem, is a important question made of subjectivity and objectivity to balance in a very difficult way. Not all sufferance is every moment visible, but the most difficult suffering to define and to treat is not visible sufferance, who has effects and impacts many years ago after the treatment. This is a drawing of a young adolescent, very happy every moment during the therapy, but you have not to be a sophisticated psychoanalyst to see the black sun and the home who looks like a coffin. This boy will have problems of mental and behavioral adaptation only years after the end of the treatment. Suffering is often inevitable, but what matters is what direction will take the sufferance. And the more important vulnerability factors are known: pain not adequately treated, the fragility of family network, impairment and severe functional sequelae. These are objective factors, but also other aspects are important, such as social isolation and absence of planning in life during the illness. The adjustment process is necessary for a clinician to integrate attention to the objective aspect, such as subjective factors, with attention to the singularity of process of adaptation, and understand the in dynamic terms the patient suffering. This is a quite important slide. The match between concept from psychiatry and clinical psychology is not so easy, and we usually only, not often, diagnosis based on classification, international classification, that are everyday matter for discipline of mental health, such as in the adult field. But diagnoses are useful. We need to use well the diagnosis. Diagnosis is not only the presence or absence of dichotomicus criteria, but is a dimensional diagnosis. And the most recent system of the diagnosis is given an increasing attention to a normal personality in DSM-5 and PDM, for example, taking in account not only clinical symptoms, but also the overall functioning of life and the resources of people in their own context. Role of personality. In recent conceptualization, personality has an increasing role, and personality mediates the long-term adjustment and functioning of individuals. Which tools and which instruments have we used to support the adaptation and to evaluate the long-term problems of survivors? It's important that the patient monitoring includes multiple perspectives of observation and, if possible, more observer. Standardized questionnaires, we look the results, the poor results good in the form, but substantially not centered in a small sample of our patient with osteosarcoma, needs to be integrated with the relationship with the patient. And we published some years ago an article about the possibility and offered by a simple instrument, a simple tool, 5 questions to present to long-term survivors to understand more deeply their quality of life behind any kind of questionnaire, scientific questionnaire. We need also more integration between mental health service and hospital, because some cases are very difficult to treat in a hospital setting of oncology. We have quite a singular situation because we work in Milan in a cancer center, and the mental follow-up of cancer survivor is very long, virtually along all life. And we have an interesting point of view about the history of this patient. The majority of other centers have only a limited period of observation, and so the knowledge about long-term adaptation is not so clear and not so evaluated. An important key point is the necessity of good integration of mental health disciplines and oncology and medicine. In Italy, this collaboration is still not so good as we would like. But the important aspect is one can be expert of everything, and only a multidisciplinary team can be integrated work with patient with the characteristic of a good craft work, because our patients are unique and need all effort to be sustained in a long-term adaptation to their disease. Now we look at the possibility for prevention. There are traditional systems such as psychological support for distressing and disadvantaged condition, but also support patients with tools adapted to their age and realities necessary. For example, the video during a recent year, patients use more technological devices. Video is recently a very important instrument where to seek information and obtain information about many problems, from practical question to psychological aspect. And in hospital we try to make videos to give patient information. Their own doctors give information. This is the only experience in Italy at the moment, and this try to match good information and a more friendly way to present the consideration. We made also two internet sites as part of youth project at National Cancer Institute. What is the aim of the two sites? They are made because skills and empowerment in front of pathology are important and can be strengthened not only with traditional form of psychotherapy, clinical talks, medical and patient visit, but also in this new way important for adolescent. There is one more way we had to try to support the adaptation. You know, identity is crucial moment, crucial target for evolution of adolescent, and the identity develops crucially through relationship. We try to empower classmates and peers with use of video, movie, to inform classmates what is the reality of being affected by cancer during adolescence, and to make this reality more known in a situation where usually disease is not very used conversation piece. Last, it's important the support by meaning of by testimonials, by patient survivors, to show what the course of treatment is, not only in an idealistic manner, but also in a realistic way. And the videos can be helpful to show what is the reality of the disease. Another concept important for us is a possibility to improve and practice physical exercises, but also sport during the treatment of the disease. The activity, yesterday Dr. Ferrari presented some of these activities of adolescent program in our hospital, and the possibility to practice a sport is very popular with the adolescent, and is important for a main reason, because offer to the patient hospitalized the possibility to counteract a traumatic experience where the body is usually suffering and object of therapy and diagnostic procedures, but in the same hospital can be object of empowerment, cure, and help about sense of integration. I'm concluding. Over the years, we have learned that the assessment of quality of life must be based not only on tools that try to be objective, but also on the evaluation and treatment of vulnerability factors already during the cure of cancer. The Center of Excellence of a long-term observatory, which has two very important aspects: collecting general knowledge on the mechanism of long-term adaptation to a serious illness. I told that in some situation it's possible to have a follow-up virtually without end about mental conditions. And founding a specific knowledge about the effect and effectiveness of intervention for prevention and support of emotional distress. If you like, the arguments and the evidence about the efficacy of mental health treatment is very poor, still very poor, and we need more research and more data to sustain the implementation of this activity. The final objective of this intervention is supporting a drive for living without giving up and without indulging in mistrust and isolation during treatment, given the opportunity to take hold of their lives. Many thanks.